Well, as my wife likes to say sometimes, we are small in numbers but mighty. But we do have several of our members who are watching online. Welcome to them. They've let me know that due to personal issues or illnesses that they could not be here in person, but they are watching online. So we wanted to start relatively close to the beginning. So it's 11:10. Welcome to the September meeting of the Medicaid Client Voice Council. There are others watching online, and this is recorded and posted on our website, so the presentations that are made for those who aren't here or miss it, or those from the general public who want to learn more about these programs can always watch it on our website at dhs.com under the Medicaid Client Voice Council. So we have several presentations for you all today. They run the gamut from home and community-based services to hospital to home, to Arkansas Care Program or Personal Care Program, and then we have some exciting news about a new council that will be starting up that will include some members from the Medicaid Client Voice Council. We're going to have two councils, and we'll explain how that's going to work, how they're going to work in tandem. It's something that's required by us as a state. All states are doing it, and so it's exciting that some of you may want to take advantage of the opportunity to serve on this new council. Generally, Secretary Putnam is here. She could not be here with us today. And generally, our chairperson and vice chairperson would offer some opening comments. Since they're both not here, but Brandy Vaughter did send me a comment that she wanted to read before we begin. She said, "I apologize for not being in person today, but I would like to thank Mary Franklin and her team who worked so quickly in implementing the changes and improvements to the Access Arkansas portal. I am also very excited about the Hospital to Home pilot program, and I look forward to today's presentation about it." And so we're having to juggle the lineup a little bit today because there are meetings going on at the Capitol, and DHS leadership is involved in those meetings. Melissa Weatherton is in a meeting right now. She'll be here as soon as she can. So Jay Hill, the Division of Adult Aging and Behavioral Health Director, has agreed to step up and bat first today in our lineup, and he will discuss the Personal Care Program. It's a service that provides hands-on help with everyday tasks. It includes a proposed update to the assessment process, eligibility requirements, and types of help available. So Jay, if you could come up and welcome.
Morning, everybody, and to all those that are online. Glad to have you in the meeting today. Thank you for being here. So, Jason, we have the PowerPoint queued up, or we're going to?
You have a clicker right there.
This is it? Green advances. Thank you for the simplicity of that. All right. Say for just a few minutes this morning, I'm going to go first, and I just want to share with you some of the things that we are doing at Aging Adult Behavioral Health on the aging side of the house. We really have been working, and a lot of I'm going to back up, a lot of our, I won't say our desires, but really our goals to make improvements have been born out of this council because of the comments that we hear, the feedback that we get, and really the understanding, the realization that there are better ways to serve our beneficiaries. We often have great intentions. We always mean well when we establish a program, but it doesn't always. It may miss the mark somewhat because there are things that we don't consider. Maybe there's experiences with our beneficiaries that we don't have, and so that I would say thank you to the council because you really are important to us. We hear what you say, and in this case, I want to give you an example with State Plan Personal Care, which is a home and community-based service. We heard that, and we have been working for some time now. This is a state plan service, and so with anything related to government, it sometimes moves slowly. State plan services are no different. But we are looking to make some changes to personal care, which is, as I said, it's that HCBS service. It's those first up to 64 hours that a beneficiary gets for those assists in their home setting for adults. In my division, for adults, there are also kids that get personal care. For instance, a lot of schools, we see personal care in a lot of schools. What I'm going to be talking to you about today are some improvements and changes that we're proposing to the system on the adult side of the house. So what I'm going to show you are some slides from two webinars that we've had, 2 successive months with provider communities, with those personal care providers, those home agencies who have told us, we can serve better if you will do this and that and this and that. They've told us what we need to know to help them take care of the beneficiaries that we have in the state. So the first webinar we've had, and I included this for purpose, I wanted you to see what our purpose statements are, what we are talking about with our providers. To allow personal care providers to hear that the division is thinking ahead of policy changes, meaning we are including others outside of our agency in feedback, in helping us understand what we need to do, and to gather feedback from personal care providers on suggestions in order to help shape an implementation of changes. What's in it for me? Meaning from the provider perspective, our beneficiary perspective, to be a part of the process, time to prepare, and to share insights with us on best practices. And that's really where this was born. So just a real quick, the current process for personal care, and this is there's 11 steps on here. We watered this down. Personal care is involved. It takes a while. It really is not always a simple, easy to navigate system. County operations determines if an individual is eligible. Then the beneficiary or the family member reaches out to a provider for services. Then that provider makes a prior authorization request to Acentra, one of our contract companies. Acentra sends the referral for an independent assessment to Optum. All these steps. Optum then performs that IA with using an ARIA, Arkansas Independent Assessment Tool, and makes a functional tier assignment. It goes back to Acentra. Acentra reviews the independent assessment. They will apply the task and hour standards for beneficiaries 20 and under, and Optum performs that task and hour standards for 21 and over. Optum then uploads those results back to a personal care, back to Acentra. Acentra assigns results to the provider. The personal care provider then performs a functional assessment in the home and completes a DMS. It's a DHS form 618, known as a personal care service plan. It's your PCSP. The Acentra then creates prior authorization based on that PCSP for up to 64 hours. This takes a while. This is a lengthy process for many of our people. And we know, and we've heard too, that a lot of our beneficiaries, they need services today. They need services quickly. It's difficult. It's very, very burdensome to wait weeks upon week upon week, sometimes months, to get through this process.
I'm just not familiar with that. What is Acentra? Can you explain what that is?
Acentra is a company. It used to be EQ Health, and it was Kepro, and now it's Acentra. It's a company that we contract with to help us manage these processes.
Okay. Just wasn't familiar with that.
Okay. So we've begun to review the ARIA, the Arkansas Independent Assessment, as the current independent, which is the current independent assessment tool for state plan personal care. If you have a family member or you know somebody that's been through this, the independent assessment is a lengthy process. It's a lengthy tool. It's a standardized assessment tool for HCBS, home and community-based services, home and community-based waiver services. HCBS does require an independent assessment per federal regulation. So that is why we currently use Optum. That is why we have this assessment tool in place. We often ask, why are we even doing the Optum assessment? It is a federal reg. And it helps us to determine the medical need and functional eligibility of our beneficiaries. However, personal care is a state plan service. It is not a waiver service. It requires a medical prescription and a service plan based on an approved functional needs assessment. All right. Proposed improvements for 2025. So these are where we're going to get into the changes of what we are proposing. We have concerns with the current state plan personal care process, and we've outlined these. Personal care Medicaid manual has our state plan service, and I love the way this word is worded, tangled up, and it's just such an accurate description, tangled up with rules and procedures that apply to HCBS waiver services. For instance, AR choices, which is our waiver that comes in behind personal care for those who may need more than 64 hours. The waiver service would allow for additional services, as well as independent choices, which is the state's self-direction model. We realized that our manuals could be somewhat confusing as we had multiple programs tied up in this manual. So we're cleaning that up, and we are removing language, and we're making references to AR choices, to independent choices, just to make the manual read more congruently about state plan personal care services. Our primary care providers, beneficiaries, have not been involved in the medical eligibility determination, by and large, in the for state plan personal care, and that is a requirement. That is a requirement, and our goal and our hope is to do a better job of connecting recipients to their PCS or to their PCP, to their primary care provider. They should be involved. They have an opinion. They very often have thoughts, and we want them to be able to weigh in on an individual's treatment plan. I'm going to show you that in just a moment. The functional assessment is being performed by both Optum with the ARIA tool, and again by a personal care provider with the DHS form. It's the DMS, Division of Medical Services, Form 618. So we're double dipping there. We're really backtracking. We want to streamline this process and make this much simpler, which we also know will expedite. It will speed up the time frame in which a beneficiary becomes eligible and can have services initiated in their home. Prior authorizations require renewal every 6 months now under our present system, which adds an additional administrative burden. So, changes under consideration, and these are the exciting things for us at the division. We're proposing to streamline the manual, the personal care manual, to focus on standalone state plan personal care, and we're close to completing those revisions. Secondly, we want to mandate that primary care providers initiate and finalize the medical assessment for personal care. We want them engaged and we want them involved. We want our beneficiaries to have that connection to their PCP. Thirdly, to transition from the independent assessment tool, my opinion, this is the most exciting piece of this, to transition from the independent assessment tool as the medical and functional assessment test for state plan personal care. We want to replace it with a much easier to use, updated tool for personal care. Our intention is to remove Optum from doing these assessments for personal care and delegate that to a personal care nurse, an agency nurse, who is already going in the home. If you remember, they're coming in behind our Optum assessment and doing those functional needs assessments anyway. There's no sense for us to do that twice. We realize we really are running down the same road twice. We want to expedite that. And then to extend prior authorizations from 6 months out to 12. The future process will much look like this, and I'll walk through this relatively quickly. Again, starts in our Division of County Operations as who is eligible. Primary care provider is identified or assigned. If a beneficiary does not have a PCP, that can be handled here through AFMC, through Connect Care. Medicaid beneficiary reaches out to the provider or their primary care or their PCP or their primary provider for their needs. The provider then will refer or will complete what we call a 618 ER. Now we've divided, I'm sorry, I'm going back here to the microphone so you see me. We've divided the 618 into two parts. You've got the 618 ER, which is an evaluation referral. Essentially, we want that PCP to make that referral for services. They're now up front and they now know and realize that Jay needs services, and they're going to make that referral. So the the provider of choice will come in behind and complete a 618 evaluation. We've gone in, we've added a few components to the 618 from the task and hours. So no longer will Optum be doing an assessment and then the 618, the task and hours, is being completed by a nurse. We've combined those into one evaluation to be completed by the service provider, who will then send that back to the PCP for signature in the form of a treatment plan. Okay? In this way, Your primary care providers are engaged. They can review that. They can agree. They can disagree. They can make suggestions. But once they sign off on that, that will serve as, for our purposes, the prior authorization for the majority of our beneficiaries. Yes, ma'am.
And Jay, if you want the freedom to roam, you can turn that handheld microphone on.
Okay, thank you. Well, I'm trying to stay for the camera.
One of the concerns I have as a parent of an adult who would be eligible for these services, and you talk about the primary care physician, I assume his primary care physician would be responsible for making a referral for services. So how well are they informed of what they're what they are supposed to do? Just from personal experience, I don't know that mine in specific would even have a clue what you're talking about.
That's a great question. I wanted to talk about that, so I'll go ahead and address that now. This is something that we have had a lot of positive feedback from PCPs over this new process. We've met with an initial stakeholder group, and we'll be working in partnership with AFMC to do asking and what our goals and our Ps to help them understand what we're asking and what our goals and our intents are with this new process. And so we do intend to have trainings that will begin probably early 2025 for full rollout by the end of the fiscal year. Okay. Essentially, the sequence of forms is across 3 steps. The evaluation request from the provider, PCP, okay? The providers, the personal care agency will complete the 618 and will submit it in a 618 adult or youth, depending on age, back to the primary care provider, will then sign off, and it will become a 618 treatment plan. It will go back to the providers for initiation of services. This allows us to remove the Optum assessment. The new tool follows the same format of the current 618, since it does include a functional assessment and a service plan. And what I want to do, I want to cut through this real quick because I know I'm running short on time, and I do want to leave a few minutes for Q&A if there is any. We're not adding ADLs or IADLs. All indicators range from minutes, come directly from the task and hour standards that we're attaching to the 618. What is exciting to me and what we realized that we truly needed to do a better job of is here at this last bullet. I want to really focus on this. Designated place to include any skilled clinical observations that should be included about the beneficiary outside the grid. We know, for instance, and it's not a standalone diagnosis, but we do know that there are individuals who have Alzheimer's or dementia that can independently transfer or toilet and eat. And so, under our current assessments, which are heavily weighted on your functional ADLs, very often those cognitive decline issues can be overlooked. Or even if a beneficiary is included into the system and begins to receive services, it may not be at a budget level that is truly adequate for what they need. They may need more continuous monitoring than what a very limited budget allows. It may be that they would go to one of the provisions under waiver services, such as adult daycare, but there's not enough hours. And we know personal care is limited, restricted to 64 hours. But this caveat, and we are truly focusing on improving our medical assessment for applicants for services. So, in both state plan services, and I'll go ahead and commit to you that we are also doing this in our waiver line as well. AR choices, our living choices, our assisted living waiver. We're focusing on really understanding and reviewing medical records, and when there is a diagnosis of cognitive decline, to give consideration to what is needed, not necessarily what your functional or your ADL deficits dictate under the old scoring system. Right. We had a second provider engagement meeting, and I kind of got ahead of myself when I told you that we're working to remove prior authorizations. We are proposing to change that for individuals who qualify for 48 hours or less of state plan personal care will no longer require a prior authorization. The PA is required only for those receiving more than 48 up to 64, which is the max. And again, we looked at our populations, and roughly just less than half of our universe of personal care recipients would fall into this bucket. So the proposed process for prior authorization for 20 and under, no optimum assessment. This should be 20 and over, I believe. May have misnumbered. We have a typo on our slide. No optimum assessment. Personal care provider performs the assessment using the new 618 and service plan tool. The personal care provider will upload the signed treatment plan, 618 treatment plan, to Essentra, and Essentra obtains the PA valid for 1 year. And that, again, this will be for persons who are receiving over 48. But removing that requirement for prior authorization really just further streamlines our program, our process. It will speed this up a little bit. 48 hours of personal care a month, again, no prior authorization required. More than 48 hours of personal care, the personal care provider performs the assessment using the new tool. The PCP uploads again the 618 treatment plan to Essentra, and Essentra obtains the PA from Medicaid valid for 1 year. Our anticipated timelines. We are working to promulgate the updated Medicaid manuals. This is our personal care and our ARIA manual, our independent assessment manual, in January or February of 2025. Stakeholder training, working with our providers and covering, truly covering, fully covering so that they understand how to use the 618 between February and June of 25, and an effective date, effective rollout of July 1, our state fiscal year beginning. To answer your question, I'm sorry, Betty, to answer your question, AFMC is working with DHS. We've begun initial outreach with small work groups of our PCPs. We will expand this out into larger groups, and training on the new process and forms to take place in early 2025 and run congruent with our provider trainings. I believe that's it, Jason.
All right. Questions? Any questions? And let me remind our council members who are watching online that you have my cell phone. You can text me your question. I'll share it, and we'll get an answer, and you can listen as you watch. Betty?
Just a question on how do we come up with 64 hours is what's allowed for personal care per month?
That is a state plan. That is a state plan max, and I don't. It really proceeds.
What input was gathered in order to come up with that? Do you know?
No, ma'am, I don't. I could get that for you.
Okay. Just wondered if that a pull from the air, or was it based on some
There would have
need,
been a formula applied to that. It wouldn't have just been an arbitrary number, but I can get you that answer.
Okay.
So I'm guessing you would like it higher. Much higher.
Again, that
64 hours a month.
It's like 16 a week.
16 a week.
what the waivers to do. So we have a waiver program called AR Choices, which is in effect a continuation of personal care. And we do recognize and realize that there are many people who need more than 64 hours of monthly care. AR Choices comes behind that and exceeds that, can actually go up to more than double the number of hours that are provided through personal care. And so for beneficiaries can receive both 64 hours of state plan services in a month, followed by additional hours under waiver in that same month to accommodate those needs. Community-based, you're not, you can exceed it under state plan hours in AR Choices.
Are you automatically?
You can exceed those 64 hours in AR Choices.
Are you automatically?
No.
Are you automatically kicked to the AR Choices, or do you have to apply to that separately?
It is an application. It is a very similar functional and medical need process to qualify for AR Choices as it is for state plan. A little bit different on the financial side, but the majority of virtually all of our waiver clients have state plan personal care, and the majority of those receiving personal care, particularly those that are receiving 64 hours, are also included in the waiver.
Okay, and then when they reapply, when the personal care, when they reapply for that after their 12-month authorization is up, is that the same process to reapply, or is it?
No, the PCP involvement is only required once. It's only required at initial. So when the nurses come out, when you do a redetermination or a reevaluation, it can continue at that point. You're not required to go back through this entire process again. This is just for your initial. And this is only going to be for new persons coming into the program. For those people that are currently getting state plan personal care, they'll be migrated into this. I won't say grandfather. They're going to be migrated into this new process that we have. They will not have to go through the PCP referral.
All right. Thank you so much.
I'm going to stick around. I'll be available. If you have other questions that come up between now and the conclusion of the meeting, I'll be glad to take those, okay? Thank you, Jason.
Well, I know Jay is saying some things that we as a council have been stressing. Try to get rid of the duplication of processes, try to streamline processes. Why do we have to be reviewed so often? So those are some positive changes that we heard from Jay this morning. So HCBS in Arkansas, we have the Director of Medicaid Specialty Populations, Melissa Weatherton, here. She is going to talk about a new home and community-based services campaign. This campaign includes one-page informational sheets and a website that will help educate Arkansans about what services are available. I believe she has showed you some of those one-pagers in the past and gotten some input on those. So without further ado, Melissa, come on up. And you did not have a slideshow, is that correct?
I don't know.
I don't think you did.
Winging it, Jason. It's been a busy morning. That AFMC, I will not take long because I'm super excited about the next presentation that AFMC is going to do to go over one of our huge art pilots called Hospital to Home. And I really want to focus on that more than this. Many of you guys saw the one-pagers and gave really great feedback on like the wording and how to simplify it and how to make families better understand by using plain language and not our vernacular at DHS. And we took all of that feedback, and so we have two versions of every single one of our one-pagers. One is an internal-facing version and one's an external, right? So the external is, has the cool like graphics and font that you guys selected, which we're very thankful y'all took the time to do that. And then the internal version, really what we're trying to do with those, it has more DHS-y stuff in it, and we're going to use those as trainings for our internal staff. So it has become very clear that we need a more robust and dedicated training curriculum for our teams who join the Medicaid program, who aren't all seasoned like some of our directors, right? And then can just kind of rattle that stuff off. You know, we're not doing a very good job internally of being able to pass that knowledge to someone else, right? To the point where many of us have a email folder that's literally labeled, if I get hit by a bus, right? Because Paul and us, we've been talking about this for years. That's one of our biggest fears. It's like, I think we're the only two people that know that, right? Maybe we should tell somebody. So what we're trying to do is take those internal facing documents and do a education management type tool. We're working with IT. We don't want to make it punitive, so we don't want to be like, well, you got to make a 90% on it, or you fail and something terrible happens, like the IT quiz, right? You get kicked off the internet for, a week. But we do want to make it where we can actually see where our deficits are. So then we know where we need to drill down more in terms of like, okay, they really don't understand X. We need to do some more heavy training on that. The goal is so that when people call, you get real and accurate information, right? And are not hopped around. Also, while we're doing it, is we have put out a request for information, which is a very state-ish term for we're asking vendors to tell us how they would run a customer service center for us. So right now we're in the middle, I think it was a 90-day window where we were asking for vendors to tell us different things on how they would do some functions that we so desperately need at DHS. So for one, we're really looking for a vendor that's going to be able to take all beneficiary calls in the future, all right? That's a huge lift because that means that we need to be doing script building internally, right? We need the vendors to come in and be able to speak on our behalf. So from the outside, the beneficiary doesn't have any idea that they don't work for DHS, that they are operating on our behalf. So that's number one. Two, we've asked that this vendor tell us how they would come in and keep our website up to date. Because Lord knows that website's a real bear, right? And you can't find anything. So trying to figure out how we make that friendlier and how they keep it up to date for us. Three, we really want them to start implementing some form of artificial intelligence, right? We're way behind the curve on that. And I think I've talked about this before. You know, I can get on my Walmart app when my milk doesn't arrive and tell them that it's missing, and they can respond on an app, right? Now, I don't think we're going to get fancy like that in the next 5 years, but we can upgrade like our chat bot. And Gavin, we've been working with communications on that. We can do some things to get us into the world, right? Into this world. So we're asking for the vendors to tell us how they will incorporate over the next several years artificial intelligence to be less reliant on human beings for everything. We're also asking for the vendor to bring a case management system. So many people probably don't know this, but you know, there is no singular portal where if you called Paula and then you called Jennifer Brzee at DD, there is no centralized mechanism for them to be entering information, which is one reason why people feel like they're repeating themselves over and over and over, right? So we're asking the vendor to bring one singular case management system that they would use immediately, and then they would phase in to where the end goal is all of DHS staff would be using the same portal, right? So we could see what the vendor said, and they could see what we said, hopefully to cut down on asking the same questions over and over and being able to give out more accurate information. And last, we want to incorporate a closed loop referral-based system to the community. So meaning someone calls this wonderful vendor, right, with a singular phone number, and they can answer all of your questions, and you say, I want to apply for SNAP benefits. And, you know, they get you where you need to be to get enrolled in SNAP. But clearly, if you need SNAP benefits, then you need food, right? And you might need food right now. So the closed-based referral system would be a mechanism where the vendor could go in and make the referral to food pantries in your community, right, to get you food instantly. Not instantly, but you know, not weeks away. So, and then the system would be set up where then they could go in and say, yes, you know, St. Joe's Church gave so-and-so this much food on this day at this time, so that we had it come back to us so that we know it's been taken care of. So this is a huge undertaking, as you can imagine. But part of what we're trying to feed into these HCBS one-pagers is just really the beginning of what we're trying to do across DHS to start building out these scripts, building out internal knowledge base, because we're going to have to be answering these questions until the vendor gets up to speed, and that could take a long time, right? But we need to get started on helping be prepared for where we're trying to go in the next 7 to 10 years. And this is where we're trying to go. We really want that no wrong door approach to treat our beneficiaries. Maybe down the road, we'll even add on providers, right, to try to make it more friendly for providers as well. But right now, internally, we really decided our focus was on giving families and beneficiaries better information, faster information, reliable information. So, like I said, that RFI, request for information, is posted right now, and vendors are responding, and our goal is to put out a contract to onboard a vendor. We're going to put the contract out in the spring. So it'll take some time. These things take forever to work through, but we are moving in the right direction. So I just wanted a few minutes today so that y'all understand how thankful we are for the feedback on a lot of this information and kind of what the underlying purpose is. It's kind of dual purposed. So you can try to see with us like where we're going. And I will be happy to come back at a future meeting and talk about this customer service center and kind of where we are as a status update.
Did anyone have any questions based on what Melissa shared so far about it? Yeah.
And I had to step out for a minute, so I may have missed it when you started. At the end, you talked about like if your client has said, hey, if you need food or something like that, is there an option to where that person could say not only like if you need food now, but like if they're talking about their situation and you have the person on the phone and you realize they don't need that, it's like, well, what about WIC? What about Section 8 maybe, a place to say, to where you may be able to offer those, because sometimes clients, they may think like, okay, I really need this and that, but they didn't know. So then you ask like, well, have you talked about this? And they go, I didn't know anything about that. So like, I wonder if that could be an option. On
Absolutely.
there as well.
So actually, the governor has formed a cabinet committee, and they developed a program called Launch. And the goal of Launch is to do just that. It's to take the state agencies and everything that everyone offers and put it into one portal. What we're trying to do is we don't have our house in order right now to get onto such a program, right? And so what we're focused on is building this program. But yes, the goal would be this will intersect with Launch. And then you'll be able to do all of the applications or referrals for the programs you need that the state offers. Exciting.
Any other questions? Also, a reminder, if you're watching online, you can text me your questions. Melissa will be here for a little bit longer, but you probably have to go back to the Capitol, I imagine. Thank you very much.
Thank you.
All right. All right, the last presentation we have before we break for lunch is about hospital to home. Dr. Christy Coward and Christy Bondurant will wrap up this Aging in Arkansas block of information that we have for you this morning by discussing the Medicaid Hospital to Home pilot program. The pilot will target 50 to 75 individuals who are leaving a hospital or a rehabilitation facility and providing them with additional support so they can remain safely at home in hopes of reducing unnecessary hospital and emergency room visits within those targeted populations. So let's learn more about this program. I'll invite those ladies up to the podium. And again, these mics are both hot, so if you don't want to lean into this one, you can use, actually I'll just leave one and I'll keep one.
That sounds good.
All right.
All right, well, I will get us started. My name is Christy Bondurant, and I'm the project manager for this pilot for the AFMC team. And this work is funded through the American Rescue Plan Act funds. It's a pilot. We're thrilled that DHS reached out and asked us to be the boots on the ground and operationalize this pilot for them. And we're also, because it's a pilot, going to evaluate the effectiveness. It's important to us to understand, what worked and what didn't work throughout this process. Like Jason said, the goal here is to support individuals in their home and link patients to the services they need, and if it's at the appropriate level of care. We know some patients or some participants are going to be a good fit for this program, and others maybe not as much, but for the type of services that we're able to provide. The goal again is to reduce hospital and ER readmissions, identify those appropriate services, what is helpful to an individual to help them remain in their home, to be either cost neutral or reduce costs as well, and then also to look for that patient satisfaction. Is this something that they felt was of value that helped them stay in their home? What was it that from their experience that was helpful, what was not helpful? All of those things are a part of this. There are several differentiators of this program. We're going to have care transition specialists assigned directly to a patient. That's one thing that's going to be key. We also have, and it's not here on this slide, an eligibility specialist, and they're going to help patients that qualify for either waiver programs or other Medicaid programs to get their application through that process, be able to be that link between the patient and the state to get this through. Well, also, something that's unique about this program is that there will be funds for the direct services, whether those are clinical or non-clinical services. And an example of non-clinical service may be, you know, a window unit air conditioner if they don't have air conditioning in the home. Although we're heading towards fall rapidly, that might be heater at this point. And, you know, to catch somebody up on their utilities, things like that. So we have 3 pilot sites where we'll be conducting this work, and one is in Garland County, and that's with CHI St. Vincent's Hot Springs, and we hope to actually work with some of the behavioral health patients as well in that program. Jefferson Regional in Jefferson County. And then we have the Southern Administrative Services group that we're going to work with. The county that's marked here is Bradley, but we anticipate that being Union County, and we're working through that process now. So that slide will need to be updated eventually. So again, just to kind of build on the goals that we've discussed so far, you know, we have a list of home and community-based services that Dr. Cowherd will go through here in just a moment. But we want to be able to work with participants to identify what of those services would help them remain in their home and support them while they're applying for a longer-term program. Some of the programs that we're hoping to link them with are the Community Employment Supports Waiver, AR Choices, Living Choices, and then not a waiver, but also a program to link them with would be the PASS. They'll have 120 days where we can form that bridge or provide supportive services. And then we'll also have a referral process, and I'll talk a little bit more about that referral process at the end. But referrals can come from many sources. You know, the 3 locations that we talked about in the previous slide, you know, those referring providers can refer, but this is also open, you know, to LTC ombudsmen, advocacy organizations, community-based organizations, families, DHS staff as well. And then with that, I'll hand it over to Dr. Cowherd.
Thank you guys again for having us. I'm Dr. Christy Cowherd, and I'm the Medical Director of Clinical Services here at AFMC. And I will be the physician lead for the pilot program that we're going to be doing. So as you can see on the slide, we essentially have 3 populations of focus: the behavioral health, aging, and intellectual, developmental, and physical disability, or I'll say IDD, or refer to that as IDD. Behavioral health patients will include both mental health patients as well as those with the substance abuse disorders. Aging individuals have been identified by DHS as a priority. So, as you know, those individuals always or usually will have an increased need for clinical and social care, and is also a growing population in Arkansas as well as other states. For the IDD patients, or those with lifelong conditions that affect physical, intellectual, or emotional development, DHS hopes to identify services that those patients need to be successful in their communities. Over on the right-hand side, there are 3 key factors that we'll be looking for as we assess the patients for enrollment in the pilot. Number 1 is the patient Medicaid eligible, either for the PASS program or the waiver programs. For the aging or the IDD patients. And then, is the patient a high utilizer of care? Do they use the ER frequently? Are they admitted to the hospital within, you know, readmitted within 30 days or so? And is that unnecessary utilization? You know, some patients may do all those things and they may actually need that. It may be medically necessary, but then there are those that are just kind of constantly using kind of those inappropriate places for those certain types of care that they need. And then the last thing is the patient at risk for inappropriate placement into institutional settings, such as long-term care nursing facilities or the psychiatric hospitals. Our team is working on supplementing, not replacing, the care transition processes that are already in place at the hospital or rehab facilities. So we want to work with them and not duplicate those questions 14 times. We're currently working on developing a patient assessment tool that includes the Medicaid eligibility information details and then the patient's ability to do their activities of daily living or their ADLs, and then the potential clinical and non-clinical needs in the home. We do want to consider, of course, lots of factors, kind of as many as we can, so that we can identify the patients who will be successful in a home setting, also while we're continuing to focus on the appropriate care. You can see on this slide various factors that we'll be working through for eligibility. A large focus is going to be streamlining the Medicaid eligibility. Our pilot patients will need to be screened for those who are going to be most likely eligible prior to enrollment, just so that we can continue those services after. We do have some specific service regions that Christy already discussed and we'll discuss later. And then, as we talked about before, individuals who are high utilizers or at risk for placement in the skilled nursing facilities, psychiatric hospitals, or other institutional settings are a high priority for the program. Our hope is that if we are able to locate or provide appropriate services, then we can, of course, save costs and get them the appropriate care that they need even before they are eligible for Medicaid. There are several Medicaid waivers and programs that we're focusing on that she had touched base on earlier, and those are going to be obviously key to this pilot. Most importantly, we do obviously, again, want to focus on individuals who will actually get a net benefit from the program. So over on the left, you will see we're going to, well, both sides, I guess, will be focusing on the clinical as well as the non-clinical services. The clinical services are going to be residential, habilitation, DME, and these are going to be hopefully, you know, if they happen to have some other type of insurance that's going to cover their DME, then we'll be hopefully covering obviously the DME that's not covered by that type of insurance they have, or just any other DME needs that they might have. And then also medical transportation, and then the private duty nursing. And for the non-clinical services, she kind of touched on this already, but like patients who have maybe some food insecurity, kind of get them in with the food pantries and things like that, churches who are willing to help. And then pest services, you know, some patients aren't even able to get home care providers to come in because they have like a rodent infestation or something, and so some of the personal care places won't even assist with that until they get that taken care of. So we'll be able to use those funds to help with the pest services. And then the environmental modifications, like she was saying, either the air conditioner unit or the heater, and then also maybe like a wheelchair ramp, things like that for their home, may just need some few modifications to be able to stay in the home. And so that's what we'll be working on and be able to fund. And then case management services as well. So.
Thank you, Dr. Cowherd. So I want to spend a little bit of time talking about the care transition specialist, because it's such a key element to the program, and really is that connection between, you know, the community and the clinical aspect of this. So the CTS, and I'll just continue to say CTS because it's a mouthful otherwise, but the CTS is responsible for identifying, helping identify patients that may be high utilizers. We actually have a team that'll be working on that. We'll work directly with the referring providers, as well as we have an RN case manager. So the CTS won't have to do this alone, but it's something that they'll be very heavily involved in. And, connecting, again, those home and community-based services and being that patient champion. We actually have a couple of staff that we're working on hiring that just to listen to them and hear their passion for community and home visits was very refreshing. We actually had a good conversation with one today, so it was a great way to come into this conversation. But each person that's a part of the pilot will be assigned a specific CTS, and that individual will follow them through the 120 days. And if they, are able to get their application approved and done before 120 days, great. That's, I feel like would be a huge success for us. But during the 120 days, that's who the CTS is assigned to, and just again trying to get those services at the appropriate level of care. So this slide just kind of gives a little visual of that CTS and their role. And I liked this quote, 1 foot in the clinic and 1 foot in the community, being that bridge between the clinical services, and you can see several examples of those here, and the community, and making sure that all of this is taken care of for each participant in the program. And then another way to look at this too is that care transition specialist is, between the patient, the pilot participant, as well as all of the various services. But I like this one too in the fact that it has the arrows going both ways. This to me shows us how important the communication and the coordination between the CTS is to help support that pilot participant. They will work with the clinical care team, social services, and health systems. And then also, again, talking about the eligibility specialists that we'll have in place, being, part of the group that is bridging the information that's needed to help with that application process to get them on a longer term waiver or program. And so here's an example of the referral form, and I will say this is still in draft form. We will have our first referral hopefully early October, and so there's a couple of things in the text that need to be updated, so just be aware there. But there is a link to this form that's provided on this slide, as well as a phone number and email address. And this is information that we can collect. We have a business intelligence team that has created this form so that it feeds directly in the data collection system that we're using. It'll streamline that data collection into a platform called Salesforce. And this form will collect patient information, caregiver details, as well as contact information for the individual making the referral. So anyone, again, can use this referral form as long as the patient is within that service region that we're working with. And then, again, that information is taken into our data collection system and we're able to create tasks to review this and finalize a process if the patient meets the qualifications to enroll them into the program. And with that, that's our final slide, and we are more than welcome to open it to questions.
Just a brief question. You mentioned the 3 areas. Are those just primarily those counties, or is it a region?
So it's the counties. It's because of the travel aspect of this, we tried to make it around 60 miles from each of the service providers. And then that way we can make sure that our CTS that are assigned to this can make it into the home, on a regular basis.
So we had a couple questions coming in from our online viewers. One is from Michelle Pedro. She says, some of those services require patients to have full Medicaid or switch from our home to our choices. Is there a better way for folks to transition or be referred if eligible for those services instead of applying?
Sit down.
I'm back.
You're in. Yeah.
Okay.
Yeah,
Can I see it again?
Stand.
Let me see it again. Let me see this. Okay, that's a great question, Michelle. Okay, so this is going to be for right now, it's a pilot. All right. So what we did was we had ARP funding that we are giving to AFMC. So this is not running through Medicaid funding right this second. But however, the end goal is we are going to set up a brand new eligibility category, and this will be a new type of service, right? So it'll be a short-term 120-day eligibility category that we're working on building right now. And then it's really like a placeholder for clients, right? That we get you services in the house very, very quickly through this new designed program while you're going through that rigorous process of filling out all that paperwork for one of our longer term waivers, right? So it's trying to make sure that we aren't impeding someone that could qualify for one of our longer term home-based programs. We're not the problem, right? That we're trying to give you some service while we walk you through. And that's what's so cool about the CTS. I'm really excited about seeing how that works, because not only is that person going to help people try to get qualified for this new category very, very quickly, but then they're going to be doing a lot of high-touch hand-holding on getting them signed up for one of the longer-term waivers. So although we're doing it in this program, in this pilot, it has widespread implications across Medicaid if this works, right? So if this works, we can see where and how we can duplicate it to other Medicaid eligibility participants. So that's what we're excited about. So right now, this is just pilot money. It'll be a brand new program.
Heather has a question, then I've got a couple more online questions.
I was just wondering if you could just, and you may have said it, I may have missed it. Could you talk through how the pilot participants were chosen? The counties, and then also how you will, do you even know yet how you will identify?
So we had some partners that we identified early on that had some interest in working with us. So CHI and Jefferson, and then the Southern Administrative Services team. We did want to work with, the hospital setting as well as the rehab facility. Like that's where the Southern Administrative Services group fits in there. And as for there's at least one of them was like, we got a list already. They know who they're frequent, like who they see frequently, and they have also identified some of the areas. So like I think I mentioned earlier for CHI, for them it's through their ER and their behavioral health. For Jefferson, they're going to look at all of them. And then, again, for the rehab piece, it's just going to be where they see potential for someone to be able to return home, and what can be done to support that before they get into, the specific program that fits them best from Medicaid.
Okay, a few questions from Brandy Vaughter. In this pilot program, will the patients be subjected to the same Optum assessment as the personal care services, or will it be streamlined by utilizing social workers at the hospital for those assessments?
I think that is a no, but you correct me if I'm wrong. Sorry.
Hey, you're fine. Y'all are doing great. So this is cool. So CMS a couple of years ago, they released these two programs called the 217 group and the 219 group. And Paul and I are learning all about these right this second. But it is the goal of it was, I think CMS was also seeing just the overburdensome steps we're having to put in place to apply for some of these other waiver programs. Now, they're not taking those steps off, guys, but they're allowing states to set up programs and eligibility categories where you can qualify much faster, right? So this program will not require a Optum independent assessment. This is really based, and that's why the CTSs are really based in clinics and hospitals, right? Because this is really, we're going to rely on doctors and PCPs to say we believe that this person meets the medical criteria, and CMS is allowing this type of program to take that. Again, it's only a 120-day program, right? So, the goal is what we're trying to balance, just so you guys know, we're trying not to set people up for failure. So we're trying to make sure we have enough medical information and enough financial information so that when we're doing the paperwork, they will be accepted into the longer term programs. And so that's a lot of what this team is going to look at is, are we asking the right financial questions, right? So that we understand what their money is and what their assets are. And again, we do, and Mary was on a call with us yesterday, we feel like we could probably ask, and Michelle will agree with this, we could probably ask questions a little bit more clearly, right, in terms of what we're asking for. And so it's also looking at what kind of questions are we asking to generate accurate information quickly from people.
And I think you may have addressed this. Will patients be receiving these services immediately upon discharge?
Yes, so that's the goal. So they so identify them before discharge and have the doctor's orders, the discharge plans, everything reviewed by an RN case manager working with the CTS to get all of that in place.
Okay. And a question from Brittany Gilmore. We are adding all these pilots to Medicaid eventually, but CMS announced cutting Medicaid funding. What are our plans to accommodate then? In other words, will reduced Medicaid funding affect the ability to carry on these plans?
Well, let me say we have not received any notice that CMS is cutting Medicaid funding. Okay. Guys, in Medicaid's an entitlement program. There's only so much you can do in terms of cuts, right? So I will say for these programs that we are piloting that, are brand new, it is never our intention to go forward and ask for additional funding. We have a lot of money flowing in to aging, behavioral health, and intellectually disabled populations right now. we want to rebalance that funding for programs that we think are more effective. So, and that is the entire goal of a lot of these pilots. I would say all of the pilots. And AFMC, they mentioned earlier, is doing, she said that will feed right into the data collection. So in all of these pilots, a big component is we need that data, right? We need the data to show we are reducing people from going to hospitals. We're reducing people from showing up in ERs, and that costs X, right? And we're going to pay for this instead, and it costs Y, right? So reshuffling our current budgets across our populations.
Okay, one final question before we break for lunch. The question is, and I'm going to try to paraphrase, but there's 50 to 75 people who can participate. How many CTS workers will be needed to service those people? In other words, what's the caseload for, the imagined caseload for a CTS worker?
Right. It should be 20 to 25. We're going to have 3, 1 for each of the regions.
And if this program were to expand statewide, you try to keep it at...
Exactly. Yeah, that would be the goal.
Okay.
So.
All right. Well, thank you so much. Thank you for a lot of good information. Now, I did say earlier that we're going to lose some of our leadership. We've already have some leadership gone. We're going to lose some more at 1. So is there any, this is real quick, but is there any Q&A from our members here that you want to ask leadership in the room, just in case we were to lose them? You can always refer questions to me, and I can get those to our leadership team and get answers to you personally. But yes, before we break for lunch, just in case we don't have enough here for Q&A later.
Just really quickly, I just wanted to say that this has been an exciting beginning to this meeting, and you guys have been working really hard, and I really appreciate all of these changes, and I appreciate all the times that you guys have listened to us. This is great. This is all great information.
All right. Well, you guys all remember this Q&A session in the future because of all the rough ones we've had sometimes in the past. That was an awesome one. I think that's it. So we're going to break for lunch. After lunch, we have some exciting news about a new council that's coming to Arkansas, a council that some of you may want to be on. We're going to show you how the two councils will relate together. It's all in an effort to improve how DHS administers Medicaid, make it more efficient, more responsive to our beneficiaries. So after lunch, we will dive into the MAC and the BAC and explain to you what those are. All right. Well, I hope you guys enjoyed your lunch. And for those of you who are joining us virtually, I know that's the part you missed the most, the free lunch. It was from Potbelly Pig. It was delicious. And we hope to see you at our November meeting so you can partake in that free lunch. We are going to spend the next section of our meeting talking about a change that's coming to Arkansas, a good change. The Centers for Medicaid Services is always offering encouragement to states to run their Medicaid programs more efficiently, to serve their beneficiaries more effectively. And in addition to encouragement, sometimes they offer mandates. And one of those new mandates is to form 2 councils. We have the Medicaid Client Voice Council, which in other states is more commonly referred to as the Beneficiary Advisory Council, or BAC. And we are going to be forming, along with other states, what's called a MAC, a Medicaid Advisory Council. So the difference between what we have now, which is the BAC, which is the Medicaid Client Voice Council, it's only made up of you guys, beneficiaries. We have people come in who you can ask questions, but all of the questions come from beneficiaries. The MAC is going to be a combination of beneficiaries, so up to 4 of you from this council can join the MAC. Beneficiaries, but it's also going to have providers. It's going to have, physicians. It's going to have members of the PASS. It's going to have nonprofit organizations. It's going to have community activist organizations. So it's going to be a wider range of people on the panel. So we're going to have 2 presentations today. Crystal McMurdy is going to follow me and tell you more about that new council, the MAC. But what I thought you guys would be interested in is, what does this mean for us, for the Medicaid Client Voice Council, for the BAC? Which we may have to adopt that name just to go along with other states for purposes of uniformity. For now, we're still the Medicaid Client Voice Council. But so let's go to the first slide. We're going to talk about these new, what is the MAC and what is the BAC. So just what I kind of just touched on, states are required under the new rules to operate both a BAC and a MAC. Arkansas already has this, the BAC, the Medicaid Client Voice Council. We are going to form a MAC. So The purpose of the MAC and the BAC, this is the overall purpose, is to advise DHS on a broad range of topics. You guys already know this. This is just for a refresher. But the coordination of care, the quality of services, the eligibility, enrollment, and renewal processes. So we've already touched on a lot of these things today at today's meeting this morning. The enrollee and provider communications. You guys have helped with newsletters we've sent out. You've helped simplify language or who should get them. I remember one of our conversations during the pandemic was we should get these to school nurses because they're in touch with some of the people that we serve. Cultural competency, language access and health, equity, access to services, other issues that impact the provision or outcomes of health and medical services, and additions or changes to covered services. All of those things can come up at this meeting, and they'll come up at the MAC meetings. And the goal of those meetings are to improve all of these categories for Medicaid beneficiaries. So what will not change moving forward with us? Our size. We're still going to maintain 16 members. At the end of this year, 8 of our longer-terming members will roll off, and we'll invite 8 new council members to join the council. Our term of service will remain 2 years. Our member selection process will not change. However, it will be publicized on our website. We'll have to, they're requiring us to post that on our website along with our charter. Right now, I don't know if our charter is on our website or not, but it will be. And so our charter and our how do you become a member of the Medicaid Client Voice Council, those will be spelled out on our website. The prerequisite that all members have Medicaid experience. All of you have are served by at least one Medicaid program. Many of you are served by multiple Medicaid programs. That won't change. The stipend and reimbursement rates will remain the same, and our partnership with AFMC will remain the same. We'll have a new contract in June or July of next year. We're operating under the existing contract, and that won't change moving forward until next summer. So what will change? So we will meet 4 times a year instead of 6. The reason for that is the MAC and the BAC will meet on the same day. The Medicaid, the BAC, you guys, will meet in the morning, and then the suggestions or the recommendations that you come up with or the questions you have that you want to introduce at the MAC, the members who serve in the morning will then serve in the afternoon, and you'll be a part of that committee. So because the 2 committees will meet on the same day, and the requirement is 4 times a year, so that's another reason why we're switching from 6 to 4. And one of those meetings will be virtual. 3 will likely be in person, 1 will likely be virtual, kind of like we've done now. Our summer meeting has been virtual, and the other 5 meetings have been in person. The let's see, the recommendation process. What was I talking about? Oh, right. I had a brain fog. So the way it works now is you guys bring your recommendations or your questions to us as an agency, and they can either answer your question right here on the spot, or we'll do a little research and I'll get you your answer. Formal recommendations will be made. This is going to work now is formal recommendations will be made by the MAC at their meetings to DHS, and formal responses will be required from DHS. And so they will be put in an annual report. What were the questions the MAC raised and the BAC, and what were the changes that were made or were not made? Not all recommendations will be adopted. We're still at both advisory committees. We don't have any power to actually affect rule change, but we have the power to persuade or to make the suggestions to the Department of Human Services on what you think would improve these programs. So it'll just be a little more formal. The recommendations or questions and the answers will be more formal. The opportunity for up to 4 of you to serve on the MAC. And we're not quite sure how that's going to work out. If more than 4 people raise their hands and want to serve on that council, we'll figure out how to work that going forward. We'll probably decide that as a group. And then, as I mentioned, there will be a formal annual report that details the topics that were discussed and the results of the recommendations. So the MAC will write that report with the help of myself and our council. So it'll be a kind of a combined effort. But Crystal's, the MAC will have more of a role in that, but we'll also be a part of that as well. So that is, and when does it start? It's going to start in 2025. So the July meeting of 2025, somewhere in that 3rd quarter, will be the first MAC meeting. And it'll be a back meeting that will immediately precede it. We'll have been meeting already for half a year, our council, and then they'll kick off their new council that will meet on the same day. So that's it. That's my part of it. So any questions about this, about how it affects our current council? All made sense? Let me make sure I haven't had any questions come in online. Nope, no texted questions. So with that, let me welcome up Crystal McMurdy. She is the Division of Medical Services Project Manager. She's been doing a lot of the research on this new MAC and how it's going to look. And so I'll let Crystal tell you more about that.
Hi, like he said, I'm Crystal McMurtry. I'm a project manager at DMS. Jason really went over how they are pretty much the same and what they're going to do. Just to reiterate that it is part of the new access rule, final ruling that this committee be created, and there's a rule if you would like to look it up. So the purpose of this is to represent the interest of Medicaid beneficiaries and provide feedback on Medicaid policies and programs, just like the current MCVC. And then this membership of this committee would include representatives from advocacy groups, clinical providers, MCOs, and state agencies. And like he stated, 25% of the committee will be made up from this committee and serve on there. There will also be representatives from DHS that would be non-voting members. It will be functioning similar. It's going to review and recommend Medicaid policies to ensure transparency and facilitate communication between stakeholders and DHS. So a little bit of the transparency rules associated with both the MAC and the BAC. That everything should be publicly available on the website, including bylaws, meeting schedules, agendas, minutes, and membership list. At least 2 MAC meetings per year have to be open to the public, so there will be 4 meetings, 2 of which have to be open to the public. These meetings will also include a public comment period and get a minimum of 30-day notice to comment. There will also be a publicly posted annual report over what they have done over the year, so people know that they're actually accomplishing something. That has to be available by July 9th of 2026. So that's why that July date, because it would be a smooth transition. It would be 1 year of services. And also, like Jason stated, very similar to the BAC, it would have the same size, a stipend, just like here. It will not be, there would not be a partnership with AFMC though. That is one difference. It would be completely ran by DHS. Any questions?
Hold on a second.
I've always been curious since I started last year. As it stands now, any like the mothership like DHS or like CMS doesn't already have a board of directors or like an advisory board? So is this going to be like the official one now? Because that's like my question.
So I'm probably not the best person to answer that. I have
a state advisory board that is directly reports to national CMS.
Just like one in general that needs like
At the state level.
or at any, I guess the question is like at any other level?
Do you guys,
Like-
leadership in the room, are you understanding the question? Welcome, Secretary Putnam. She snuck in.
For all of you who are participating both here and online. There's not an overarching board that meets for everything DHS, but different divisions of DHS do have different boards and commissions and councils like this one. A few more examples would be the Child Welfare Agency Review Board that does licensing for residential care facilities. We've got the Drug and Alcohol
Advisory Council.
Yes.
Which is made up of consumer
The DD board, we've got the state institutional board. So there are a number of different, but there's not an overarching one. I mean, I think probably the closest that we have to that is sort of a legislative partnership where they have the Children, Youth, and Families Committee. That's probably not the right. That's not their full name, but so there are some legislative committees that really deal primarily with DHS issues, but there's not a full board that's just for the agency. Was that okay?
And so I had a question come in from Brandy. Is the length of term going to affect the ability to serve on the MAC? For instance, those who are having just completed their 2-year terms. This is a wrinkle we haven't quite ironed out yet because the MAC is starting in July and we rotate our membership in January. How that's going to affect which members on this council serve and for a term on their council, we're still, because of that 6-month difference in membership, we're still trying to figure that out.
And it may be that it's a short term the first time and then we cycle up together.
Or it may be that one of you who are on the MAC actually end your term with this committee, but you continue on for 6 months with the MAC, even although then you won't have met with the BAC before the MAC meeting. So yeah, we're still working that out.
All of them?
Yeah, I haven't had any other questions come in online. Any other questions in the room?
All right.
Do you have any thoughts on how we select our membership from this committee to serve on the other committee? Because we're open to suggestions. If you don't want to share them now, you can always email them to me. Yes.
I know with this committee, when I was asked to join this committee, it was from like a different perspective. Every has a different group. Like I'm behavioral health, and someone else may be, something else. Will that could be something to go on for the next?
So you're saying make sure that the 4 people who come from this committee represent as much of the Medicaid population as possible. Yeah, that's a good suggestion. Yeah. And that's how we choose the 16 who serve on this council. We take into consideration what Medicaid services do each person receive or their loved one receive, where are they from in the state, what's their age, their race, their gender. We consider all those things. And it's we only have 4 coming to that other council, but that's probably should be at the top of the list of considerations. Yeah. All right. Any other questions or comments? All right, so we did a little bit of open Q&A. We've got an hour left. You're going to obviously be leaving a little early. If there were any other questions that people had, we still have leadership. We have Secretary Putnam now in the room. We can entertain those questions or we can adjourn early. You have one question? All right.
So I think Yolanda, you had questions about this before, and I just found out. So my daughter that's diagnosed with ASD, I just found out I was able to get personal care services for her. But I also discovered that it was very limited, the amount of services they can provide. And it was basically whatever she can perform herself is what the caregiver can do for her. Well, for someone that has developmental delays, that's very little. So basically, it's kind of like a babysitter. But they can't bathe her. They can't prepare meals for her. They can't, anything that she wouldn't normally be able to accomplish herself. And this raised the question to me, and I guess this is like the perfect time with the MAC being created, where there will be different parts, like agencies working together, or maybe, maybe this question can, I guess I'm trying to figure out like who decides those kinds of things, like what kinds of services are provided through the personal care agencies, because I feel like even the agency said, well, how is that fair from an elderly person with cognitive issues that's not able to do these services? How come they get those services, but a child, you know, based on their age, why is it almost seems like it's discriminatory based on age? Because it's not based on ability, because an elder can perform those services themselves if they have cognitive deficiencies. So why are children, because of their age, not able to get those services? That's my question.
So is there anyone left in the room leadership-wise? Jennifer? Okay.
Hey, I'm Jennifer with Division of Developmental Disabilities, and I'd love to give you my card, and you can reach out, and we can definitely look into your specific case. Is it with the PASS, or is it with just regular Medicaid?
Medicaid through SSI, cause,
Okay.
But it's through the agency themselves that they said that like, I guess whoever decides on what services, I don't know exactly, I don't remember where the letter came from, but they said those services were not something that was covered. It wasn't like a covered services.
And we can definitely look into that. With kids, it's a little bit different because there's an expectation that you have parents that are doing some of that caregiving activities as part of natural supports, like you would with your any children that you had. And so I think that's where sometimes that gets squishy. And so I would love to give you my card, and then we can look deeper into that for you.
Yeah, for sure.
Yeah.
Yeah, thank you.
All right. Any other questions? Yes.
I just have a comment just to say that today was just like a refreshing meeting. I know sometimes we can ask questions that may become a little harsh, or like we really want to know it right now, but like today was, I mean, all the different slides and presentations that you all did were absolutely great. It's like they're listening. Not to say that y'all weren't listening before, but we can tell that you all are working on our behalf, and I just want to say thank you. And you can send it back to the people that work under you. I know in my case with behavioral health, sometimes it's tricky trying to learn a bunch of different things with your kids and other family members, but I just want to say thank you.
Thank you, Yolanda. Appreciate that. Some days we can leave feeling challenged and discouraged, but I think we're going to leave today feeling uplifted and encouraged. So we appreciate that. Thank you for those who watched online, and that concludes our September meeting of the Medicaid Client Voice Council. Drive home safely.